The first was on adequate production of food. Here we aggressively promoted on the concept of kitchen garden at individual level and community level. So people who have implemented here long-term programs on community health, so they must be aware of kitchen garden concept and how to promote diet diversity through kitchen garden. We identified vulnerable families and linked most of the families with the horticulture department for seeds and all, and also the entire methodology how to grow community kitchen garden, and also at the individual level. Then the second is diet diversity. Access of food agar hota hai, to many places in Odisha, Jharkhand, in Madhya Pradesh, habit of food habit is a main concern. Even if they have access to good food, women tend to eat at the last, and the practice of eating the kind of food they eat, we all know, is unhealthy. So diet diversity, we used to widely promote अच्छे खाने की थाली 3 रंगों वाली. So, and this was a hit in as far as Madhya Pradesh, Raheli block and other areas in Jharkhand, this was quite a hit. And then another critical area of focus was promoting infant and young child feeding. Infant and young child feeding, 3 important concept. It's very, very tough to intervene, but here we identified community champions known as Badlao Didi, and these Badlao Didis are part of the self-help group members. So inko select karke we used to do a proper vision building exercise, and with that, until and unless Badlao Didi is confident enough to move to the SHG or any forum, village organization of federals, to discuss on issues and impact of undernutrition, is just kind of sensitizing and discussing at the monthly meeting, and also to do home contact with the target population. And women empowerment, this we haven't been very successful, but yes, we sensitize on women access to government schemes, entitled their roles, entitled rights and entitlement, and also access to food security schemes, public distribution ho gaya, and any other food-based schemes. So this was the entire domain of intervention, और ये पूरा चारों 5 चीजों को implement करने के लिए it requires in a phased manner 3.5 years time. And next slide, please. So this is the methodology how we implemented. So in phase 1, we implemented few of the very soft approaches on nutrition, improved cooking practices ko kaise karna hai, then how do you ensure fruit, as I talked about kitchen garden farming practices, and also importantly maternal care during delivery and also after delivery. Then this all took 6 months to implement at field. And then in the second phase, it's a more kind of intensive on infant and young child feeding, helping Badlao Didi to understand malnutrition, complementary feeding, and then the childhood diseases and how the childhood diseases are linked to undernutrition in children, specifically under 5. Next slide. And then we moved on to phase 3. Phase 3 discusses more about rights and entitlement, and early marriage, domestic violence. These are, more of the underlying causes to undernutrition. This was the range of resource material was prepared specially for Badlao Didi. We didn't use, here I would like to highlight, we didn't use any technology, but now I feel post-COVID, it's important that all these topics, all these messages are highly, we need support from other professionals, how to use technology to impart these messages. But in a 3.5 years time, it wasn't. We never had the opportunity to use technology at community level because due to several limitations. So this is how, as I said, how did we worked with Badlao Didi community champions at present also. I think Krishna ji will share in Madhya Pradesh, there must be in her in her implementation areas more than 800 to 1000 Badlao Didis actively working, self-motivated, and they have been very, very instrumental in linking the community self-help group women with village, many government village institutions, whether it's VHNC, VHND, Anganwadi centers and sub-centers for accessing these services. So this is all about the community-led approaches with regard to early evaluation due to pandemic. Last year we were like completed 3.5 years of the program, but we couldn't do, to be very honest, the final evaluation. But we had an early evaluation and the result was, to be honest, there wasn't any increase in the complementary feeding, but yes, on the access to service delivery, there had been a 5 to 10% increase on each and every continuum, whether it's ANC services, whether it's access to ration, THR services, or it's immunization, any government delivery services, there has been increase, but not in the changed behavior practices like exclusive mothers feeding, if we take, and if we take complementary feeding, those are very, very sticky areas where we didn't see even a 1% improvement, to be very honest, in 3.5 years. That was the early evaluation from Jharkhand and from Madhya Pradesh. Next. Next slide is Badlao Didi in Jharkhand village. And in Jharkhand, there are more than at least 2,200 Badlao Didis. Last year, when we closed this, almost we were able to see 1,200 active Badlao Didis working at their hamlet and tola level villages, triggering discussions. कोई नया प्लेटफॉर्म तो उनके लिए नहीं था. हेल्थ एंड न्यूट्रिशन एसएचजी लेवल प्लेटफॉर्म में दे यूज्ड टू इम्पार्ट सेशंस. Next.
Yes, Runa,
yeah,
a few minutes left.
Yeah, sure. So these are just the role of how the Badlao Didi performed with the tools, with the communication tools, photographs. Next. And these are some of the activities. The other members would share more insight into this, but as I shared, linking agriculture with nutrition, we promoted kitchen garden, use of teen rango wala platter, in some places mushroom cultivation also, wherever we found an apt opportunity for changing food habits. These are some of the activities we did at the project locations. Lost tribal recipes we promoted. We helped for local varieties to grow millet, maize, citrus food, and above all, hand washing. Next, and these are some of the community level camps and events we used to do every quarter to reiterate the messages at SHG level, and also different layers of self-help groups, the voluntary organization and also the federation. The photographs is of Jharkhand with adolescent girls. This is, I think, on National Nutrition Week. Next. So these are some of the photographs of different areas that we worked. And lastly, next slide. The last slide also talks about resource materials that we were prepared with close cooperation and coordination from government of Jharkhand. trained Sayyas, and through Jharkhand Integrated Development Health and Nutrition Program, training almost 6,400 Sayyas. So thank you.
Thank you, Runa. Thank you so much for this, for sharing with us your grassroots project, and how you spoke about the holistic approach to creating village level models or the community based models of of targeting malnutrition of children, and how we started with kitchen gardens, the Badlav Didi, how a community person goes into the community, tries to bring change, involves the community in all the work that is being done, from kitchen gardens to increasing the food basket, engaging with children themselves, and the community. Finally, also on how this would only impact if you are working by building synergies across public system strengthening to community empowerment. Yeah, that those are the focus discussions that we had, key points from what we took from you. Now let me kind of invite Dr. Sriti Pavaji. Sriti Pavaji has a vast experience on this issue. She's worked with children, education, adolescent nutrition. Sriti Pavaji, welcome, and please share your thoughts on this.
Thank you. Thank you. Thank you so much. I hope I'm audible clearly, because I kept kind of missing you. I don't know whether it was okay. Krishna gave me a thumbs up. Cool. So first of all, I thank you for the opportunity, and I think I should start by definitely applauding Grameen India Foundation for setting the stage up, really, to learn. I mean, I know I'm the second speaker, but the wealth of knowledge that has come up in the first presentation, I'm really ready and charged up to soak it up all in the coming up presentations. So yes, Krishna, like you said, pandemic has played havoc. It has, we had been fighting malnutrition. It has in fact now has various directions. There is an undernutrition and there is an overnutrition. So NCDs are also rising. NFHS 5 data, you said, it has kind of shown the trends there as well, disturbing trends. And on the other side, SAM that you mentioned, severe acute malnutrition, and Runa ji, you also mentioned how, so we are really, burning on both ends. So for today's presentation, for today's discussion, I thought I will bring in something called, what I like to call, an MOC mindset. Are you able to see my screen, everyone?
Yes, yes.
Great. So I thought I'll talk about this mindset that I like to call MOC mindset. The pictures that you're seeing are from my website. MOC stands for Missed Opportunities Cognizant Mindset, which is the central premise of my book that that came out last year, and the book is called Of Missed Opportunities, One Too Many. I truly believe that in any scenario, even one missed opportunity to address for social impact and to address nutrition is one too many. We can't afford it. And after the pandemic, really, we just cannot afford it. So what I did today was from the book, and the book is a compilation of case studies of projects that I have led and designed from this mindset. And I've picked up some case studies that come closest to the theme today. But really, the point that I would like to make us all, and why I kind of applauded this interface, is that while we all work on our independent missions, and it is very important to have that hyper focus, in my last 20 years, I have seen value in once in a while, kind of looking at the bigger picture and kind of, I'm going to say something hugely inappropriate, so to say, in the sense, taking the eye off the ball to see and to realize that all of us are bringing a piece of this big, gigantic puzzle. whether it is social impact or when we say nutrition, it has various dimensions. So how each one of us can see the projects, that how each one of us can see the whole picture, and try to make sure that as many missed opportunities are there, are kind of we address and look at. And I did have a video that, if time permits, I'll play towards the end, but that brings home this point of missed opportunities. But what essentially it means is that while you're focusing on one thing, there are these other gaps that exist, which we tend to overlook. And the case studies that I have picked up will prove to you that it is possible to look at those gaps, and it is possible to kind of increase the return on investments, increase the scope, the length, and the depth of the project. And sometimes I explain the missed opportunities cognizant mindset by saying it is convergence inside out, in the sense that it is not a third party or an outer force that is bringing people together. We all know the advantages, but the perils and the challenges of convergence and collaborations and partnerships and interdisciplinary talks. But I think the MOC mindset that I think has helped in the projects that I'm going to share with you, bring out this analysis and have this reflective space that, okay, this opportunities exist. We can't do it all, but how can we consciously make an effort to seek out partnerships, to seek out collaborations? The first case, the picture that you see here, it's quite old, but it is back from, I think, 2010, when I had joined these NGOs, and fabulous ones. These are education NGOs called Pratham, and this is basically from their Asar Center's initiative called Annual Status of Education Report. In fact, this is from Paheli, which was a rapid assessment surveys that were being used across the human development domains, right? So this picture is from Umar Bahari village near Lucknow, where we were testing these piloting these survey instruments. But the idea here was an approach that has been used for education. How can that, the rapid assessment approach, how can that, and the social audit approach, how can that be used by this organization, which is typically not really 100% focusing on nutrition? Their focus is education and social audits, but how nutrition and can be embedded. And in fact, as part of this, a very simple tool was created, and it is all aware. I mean, the details would be there on the website. But how this exercise, this cumulative investment in the tool that already existed, led to this data from 12,000 mothers of young kids across, I think, 8 districts and 7 states. So this innovation at scale was attempted. These pictures that you see are from early years program. When I say early years, these are less than 3-year-old programs for less than 3-year-olds. These are, I've just collated these pictures from Chhattisgarh, Odisha, and Delhi. And here, what was attempted was, again, the main objective or the main funding for the project, the primary aim was to engage with less than 3-year-old kids in non-formal psychosocial stimulation. And it was a very kind of a renowned ECD group that we work with, and how the missed opportunity of using these touch points to address nutrition were used, or to using these early years kind of engagement with the community, with the mothers, with the parents, to address nutrition and health as well, while focusing on what was the primary focus was attempted. Okay, these are again early years programs, but these are preschool programs, and the pictures are from Ahmedabad. And here, basically, and the next 2 pictures that you see are basically these ladies who used to lead these programs. These were NGO managers, regional managers in Ahmedabad, and this group is from Odisha. And in fact, in Odisha, the study that I'm mentioning was the first RCT that was done in less than 3-year-old kids with the focus on psychosocial stimulation, but how those 2 years and very intensive touch points were used to bring in the expertise of the innate expertise of the NGOs of on-ground implementation and this rapid participatory assessment to kind of create evidence that was understood by local women, that was kind of delivered by local women, and also that was acted upon on a weekly basis. So what I'm trying to kind of, these case studies, the point they're trying to make is, while there is a platform that exists for a program, how, of course, there are points, there are kindling temperatures, there are milestones that you can't just set out to do everything together, but how these touch points appropriately can be strategized, and the program design can be looked through MOC mindset to kind of increase the return on investment. This is another example. These pictures are from Rajasthan. And here, I don't know how many of you would be aware, but there is this survey called, this ASER is an acronym, and it stands for Annual Status of Education Report. This report has been coming, this is an initiative by this NGO that I mentioned, and has been on since 2005. Every year, learning level reports, and this is a very simple tool, and learning level report is created. 30,000, close to 30,000 volunteers are involved. It goes to all the districts in the country, and the learning level report is kind of brought out, and how, and because there was this whole network which was set up, how this network was tapped, and these are Gates Foundation funded projects, how this network, this expertise was tapped strategically, and how the designs were made in such a way so that this can be used for doing the same thing in health. The infant and young child nutrition, MIYCN domains was one domain, and adolescent health was another domain. And of course, I'm happy to provide details. All these case studies are there in the book. This another program was for skilling, wherein grade 8 kids who used to flunk in grade 8, basically this was the program that were taken in to do grade 10, like an open school thing. And then there was this need to put in some skilling effort there. So what we did was we very minimal investment, because this was a home program and we didn't have any funding, unlike the Gates program. And here we kind of with very minimal investment, those faculty were trained to kind of bring in the early years nutrition and childcare messages. And what you see is a project. It was like a capacity building course that was created, and obviously, and kind of to reach out to these women. And this was the spread of these efforts. I'm not saying the entire states were covered, but if you do the cost benefit analysis really, and there is data that is available to kind of see how strategically, and if you make changes, cumulative changes in the design, and kind of look across the silos, then innovations are possible. Like I said, NCDs is another area, and this particular NGO that I have been associated with for some time is called Arogya World, and they have found a very innovative space, missed opportunities that I say, in where people live, work, and learn, in the sense that the preventive healthcare messages are brought to the students in schools, to the community, to the workplaces, of course, in the community and workplaces and schools. So again, while the primary focus of all these spaces is XYZ, the model is to kind of use the organization that is already available to kind of percolate with the relevant messages. These are last two slides, and I'm very happy that and this project I'm really proud of. This is one of my most recent projects. And this is really the partnership, the missed opportunities that industry partners are coming together to find in themselves. This roundtable happened earlier in June, wherein SHM invited all its food processing industry partners to come together and brainstorm what they could do for the malnutrition. And as a result of this roundtable, as the next steps, something called FAM, Forum Against Malnutrition, has been constituted. I'm very proud to be the core member in this forum. And what this forum is trying to do is trying to see collectively how these partners can come together, work with academia, work with research, work with government to, in all these domains, the domains that have been, the themes that have been identified are undernutrition, including SAM and MAM, and micronutrient malnutrition, and of course, NCDs. So the point I would like to make is that now more than ever, it is required that we look at, yes, the opportunities, but also the missed opportunities, and really see we can't do it all. We are focusing on our thing that we are doing, but it'll be good to kind of, be cognizant of the space and see, okay, what is it that we can do together? We can do together all the time. We can do together as one part of our work. And I think I do believe in the power of cumulative works together. What you see on your screen is the book and the website, and I'm available. I leave my contacts in the chat if it allows, and we can talk about it. And moderator ma'am, if there is time available, I'd like to show a video, but not important. It was just to make a point. I think it's an interesting video. I like it. But if you allow me, it's a 2-minute video, but it's not necessary. I've said what I had to say. So up to you.
Thank you, Smriti ji. It was a very, very detailed, and you could touch upon so many aspects in such less time. And within the time limit, you just got over. It was 45. It just got over in 46. I would just know if Krishna, one of our speakers would want to leave early. Can we have 2-minute time for this video?
Yeah, so
I'll keep it ready.
We'll see the video at the later part of after having.
That's better. Once we have heard, yes. So, but I would not want to repeat what Smriti ji said. It's such a detailed note that I've made. You've touched upon everything and how important it is to look at the larger puzzle. What you just said in the initial part of looking at different blocks together, and how we need to work on each of the block together if you want to bring some change. And finally, on the collective efforts of everyone, be it the corporate, be it the social sector, everyone coming together, and the Forum Against Malnutrition, I think, will make very good changes, and together on research on every aspect of malnutrition. And as we move on to the next speaker, we have Shweta Chandani, product lead for Life India. She would be the third speaker because she has to leave slightly early. So I request Shweta ji to join. She's with us. Shweta, are you with us? She's connected with us. Let me just check.
She is here, but
I think
she's facing some issue.
Okay.
So
we take 30 seconds to wait, or we can.
Right. No, we can go ahead with Harish ji. Yeah.
Okay. So we go ahead with Harish ji. Harish ji, welcome again, and Senior Technical Specialist, Child Health and Nutrition. Harish ji, please share your thoughts. The way you have been working, you work with a very large organization, the vast experience. Please share.
Yeah. So am I audible?
Yes, very much.
Okay.
Very clear.
So thank you so very much, and hello and everyone. Good evening to all of you, and especially I want to thank Grameen Foundation for giving me this opportunity to share my views and experiences that I have been doing in the field of nutrition. And I think this is very important topic that you have selected, and this is the need of the hour, that we need to discuss more about the nutrition, and especially the undernutrition in the children. And when I was reflecting on the topic which was shared by Dr. Krishna, It was really wonderful. But then, since it was, I thought then I should discuss about the prevention of undernutrition along with the management of child malnutrition. So that is how I thought, and which is important. So the genesis of malnutrition begins basically from the preconception of the stage. Let me, can my screen be shared, or I'll share my screen from here?
Sure, I'll share this.
Okay, right, right.
Okay.
Let me share from here.
Okay.
Oh, sorry. Sorry.
We can see it.
No, I think I
No.
posted the wrong screen.
Okay.
Sorry for that. Yeah, or else the person whom I've shared, she can share the screen.
Is this the right PPT, Harish sir?
Okay, no problem. I'm sharing it now. I hope.
Okay.
Can you get it? Can you see it?
Not yet.
Not yet.
Or else you share it. Sorry for that. There is some disturbance. Yeah. So can you, okay. So yeah, please play that in the full mode. So yeah, next slide. Yeah. So basically the genesis of malnutrition begins from the preconception stage. And there we feel like most of our adult mothers who become pregnant have the deficiency of some sort of nutrition, especially the micronutrient deficiency like iron, calcium, and folate. So deficiency of micronutrients such as these need to be addressed at the pre-conception stage. So in the journey of the malnutrition child, the first 1,000 days of the child's life is very, very important. And so the fetal stunting, which happens at the first week of the after the pregnancy, and that is one area which we need to look into, and especially in the second trimester, where the peak fetal length and velocity occurs around that period. So, and in the third trimester, where the peak weight velocity occurs around third weeks, 30 weeks. So these are the stages where the nutrition of the mother is very, very important. If the mother is do not have the enough nutrition, she's tend to become she's tend to give a poor birth outcome, and especially if child is born to her, the child will born with the low birth weight. So that is why if we have to address the malnutrition in the children, the holistic approach is from the -9 to 24 months, which means from the pregnancy to the childbirth. And so in our country, basically, especially if you look into the poor economic socio communities, the women do not get the sufficient nutrition, and which is why the birth outcomes are always poor. Even the birth outcomes are good, but then if you see when the child is born with less weight, majority of the children. So an FHS force says that 19% of the children are born with a severe wasting, whereas almost 30%, 39% children are born with the wasting. So which means that children, when they are born with the wasting stage. Next, please. Next slide, please. So when the child is in the embryo, when the child is in the womb, 70% of the brain of the child develops within the uterus, which is why the nutrition of mother is also important if we want to address the child nutrition in a holistic way. World Vision has adopted an approach which is called time and targeted counseling approach. There we have taken a holistic approach which basically addresses 7-11 interventions. 7 interventions for the pregnant women, and 11 interventions are basically for the newborn. 11 interventions basically includes the IYCN practices, essential newborn care practices, adequate iron, full immunization, and many other things. So there is a list of intervention which we basically promote during the when the child is born. But during the pregnancy, there are the 7 essential nutrition intervention that we basically do, and these intervention basically ensures that there is a mother is healthy, mother will give a birth to a healthy child. So which is why these interventions are important, and we have taken this approach in the next slide, please. We have taken this approach as a time and targeted counseling approach, which basically address the holistic view of holistic development of the child. It basically promotes the 7-11 messages, practices that I shared with you just now. Among the mothers and family members who basically adopt the mothers who adopt these behaviors, and family members who basically influence the behaviors. So those are these messages are told to them, they are disseminated to them through this scheduled visit at the household level by the health worker, by identifying the barriers at the household level. If there is any barrier, which is why mother is not adopting those behaviors, so the health worker basically identifies such behaviors and then provides the counseling based on those gaps, and then using the negotiation skills and behavior for the behavior change communication. Negotiation skills means if the mother is already doing those behaviors, she will just appreciate it. But any behavior which she is not doing, those behaviors are basically promoted during the household visits. So it is timely, and it is targeted to the mothers who are supposed to implement practice those behaviors. And the counseling, as I said, counseling encompasses both identifying the barriers and also like promote and using negotiation skill for the behavior change. Now this model, which basically basically focuses on the holistic nutrition development of the child, or holistic development of the child, has a this is the basically social behavior change communication model which World Vision basically adopts at the individual level, where the behavior is practiced by the mother. So and at the household level, basically her husband and mother-in-law, who is basically the influencer. So the communication, our health worker, especially the front-line worker, will visit the key messages and influence these communities. And at the community level, there are faith leaders, CBOs, and peers, which are, again, there is a model which basically bring all these stakeholders together to ensure that they ensure that they influence the community in a positive way and provide the services. So that behavior is taken at the community level. And the last layer is basically environment, where there is a service provider, policy makers. We bring them together, and because behavior is not practiced by one person particular. One way. It is not influenced by one factor. There are many factors which influences behavior, whether service availability or service utilization. So this model basically brings the convergence between different departments, so that there is a uptake of services in these things. Next, please. And this is the this is the timeline health worker formulates and visits each house, pregnant women and children and newborn in different point of view, and especially different point of times. There are 4 visits conducted by the health worker during the pregnancy, and so far we have touched around 151,000 pregnant women who have been given messages on behavior change communication, and they have adopted those behaviors. And similarly for 8,000 mothers with the newborn, and around 54,000 mothers of children less than 5 years. So these messages are basically delivered to these, and this is we have done in 1 quarter. Next, please. So overall, Next slide, please. Hello. Yeah. So before that, so there are, yeah. So in our in this context, in this program, basically our health worker, accompany the health worker, especially the ASHA worker and Anganwadi, and provide them all all the support at the household level. They go along with the storybook where there is a negative positive story, so that mother follow the positive story, and there is a household book where all behaviors which are basically practiced by the mother and which are not practiced by the mother also written there, and then health worker basically follow the behaviors which are not practiced by the mother, and she does the negotiation skill with her and help her to adopt those behaviors. So these are some of the IC material that we adopt. Next.
Harishji, we are kind of
Yeah,
up
next
with the time.
last slide. Yeah.
Okay.
And this is how the curative approach we have taken is basically Poshan Sanja Chula approach, which there is an article on this, how we have been able to rehabilitate these children who are basically severe underweight and moderate underweight, and we were able to bring them to the normal nutrition status in the 6 month. And the other approach is basically community management of SAM children, and we were able to basically identify 40,000 SAM children, and those children were basically again enrolled in the CSAM program, where they were followed and visited by the community health worker, especially the Anganwadi worker and ASHA worker, and given every kind of support so that these children are come to the normal stages. So this is a brief about what World Vision has been doing in terms of both preventive and curative approach in terms of reducing the undernutrition in children among 5 years. Thank you.
Thank you, Harishi. Very detailed presentation and how you brought in the aspect of pregnant women, how the entire malnutrition discussions should start from the fetal stage, and how important it is to work with pregnant women when it's from the stage of the fetus. And also on the specific part, which is very interesting, is the time targeted counseling. So all of this with and your IC around social, bringing in the social behavioral change is the model that you have focused on, and it's a very holistic approach and such a big thing to reach out 54,000 women in your project to kind of bring change. So thank you so much, and we all know how important it is to work at the community level and how to deal with malnutrition and a community-based approach. So that is very important in the entire aspect of managing malnutrition, or fighting malnutrition, and how important it is to kind of work at that level. Thank you so much, and I welcome back Shweta Chandani. I hope you're with us now. And
yes, definitely.
Yeah, please, Shweta, please share your ideas, your thoughts on this.
So, hello to all the ladies and gentlemen. I'm Shweta Chandani. I'm a public health nutritionist and a product lead right now working with 4Life India, and it's an immune system company. So, thank you so much for such a warm welcome on this prestigious forum. Special thanks to Grameen Foundation for inviting me, and also like to give a huge round of applause for my co-speakers who have given some enriching ideas and strategies and approaches so far. So, when I started in the field of public health nutrition, always I used to hear about the dual burden of malnutrition, and in my professional experience I have actually witnessed it. On one hand, I have seen malnourished children and mothers and such a high maternal and child mortality rate. Though we have come quite far, but still there is a long way to go and be at par with our Western counterparts. On the other hand, when doctors, nutritionists and dietitians in urban parts of the India are warning of the spread of obesity and its consequences, we are eating way too much while others are starving. So close to, if we look at the data, close to like a billion, people, 1/8 of the world's population still live in hunger. And each year, 2 million children die through malnutrition. So according to the NFHS 5, the number of children under 5 years who are stunted in India has come down from 38 to 35 approximately, and the number of children who are underweight has come down from 35 to 32, but still there is a long way to go. So I would like to give highlights on two things, one of which is prevention of integrated cycle of malnutrition, which needs to be addressed. And the second thing is the relationship between, like the gut health, malnutrition and immunity. So whatever I'm going to speak is some of the points are already there in the policies, but there should be strict advocacy measures to incorporate this in the system. So our foremost priority is like the removal of poverty, hunger, malnutrition, diseases and illiteracy, and all these work in synergy, they work in concert. Also, when we are educating, girls, the adolescent girls, they become more responsible mothers for the future, and they understand their rightful roles in the society. So they should be more empowered. There should be strict laws on each and every village level to discourage child marriages. So with this, the vicious cycle of malnutrition that needs to be broken. So dropout from the schools should also be strictly not allowed from the schools, because that creates a lot of problem in the future, because then they are getting married early, and the vicious cycles of malnutrition already begin. So, and also as we all know, education is a very, very powerful tool when it comes to behavioral changes. So school curriculums have already incorporated activity-based health and nutritional practices in the curriculums. That must be very, very seriously taken at the school level, so that the kids understand the importance of balanced diet and nutrition. So the nutritional changes are most likely to be sustained when they occur during the time of developmental transitions such as pregnancy or adolescence. So adolescent, if we look, it is a period in which the malnutrition in future generation may be addressed, because it is like the first life stage at which the pregnancy becomes feasible. So, like this intergenerational approach should be undertaken with cross-disciplinary collaborations to have the best chances to impacting underlying socioeconomic determinants. So the second highlight of my session, of my small talk, will be about the hidden hunger of malnutrition, which is the micronutrient deficiencies. And we should be looking at approaches. We are doing good at the supplementation level, but we are not paying good attention to immunity and gut microbiota, which is a very upcoming field, and a lot of people are doing good amount of studies on it. So the thing is, we should be looking at approaches. We are, because when the immunity is good in the children, they will fall off sick less often. And when they are feeling, falling less sick in combination of being malnourished, there is less chances of child mortality. So there is no actual starvation or death from starvation exactly, but there is a widespread mortality from diseases which are caused by malnutrition and poor immunity. So improper hygiene and eating practices directly impact their gut health, and 70% of diseases, as we all know, start from the gut. So if your gut health is good, more than likely, the children of a country will fall off sick less. Also, being sick frequently with being malnourished has a devastating consequences for mothers, and it has been linked to low birth weight and birth defects, mental and physical, problems, and poor education outcomes, etc. So contaminated food, as we all know, is the major cause of diarrhea, and sustainability contributing to malnutrition, which is accountable for killing millions of people each year, and most of them are children. So malnutrition continues to threaten the lives of millions across the world, while children being the hardest hit. So what would from my side, I would like to recommend that additionally, if you look, that diarrhea is the major contributor to malnutrition, and which includes pathogenic elements of the gut microbiota, and diarrhea leads to malabsorption of essential nutrients because the gut health is not good, and reduced energy availability, resulting in weight loss, which can again lead to malnutrition. So there's a lot of data that indicates a link between gut microbiota and malnutrition in children, suggesting that treatment of childhood malnutrition should include measures that support healthy gut microbiota. So we should incorporate the use of probiotics and prebiotics in combination. So probiotics, as we all know, is the good bacteria, and prebiotics is the food for that bacteria. So if we are giving a supplement which is a gut health supplement which has a combination of pro and prebiotic, that can help children really at a mass level, because many of the children in our country do not have access to clean, hygienic food and water. So along with the behavioral changes, if we try to incorporate something like probiotics that can help in their immunity, their brain health, as well as their like the gut health, because when the gut health is good, you can get rid of a lot of diseases, and also like the immunity is much better. So incorporating the use of pro and prebiotics in combination can be of huge advantage. Having high fiber meals, drinking plenty of safe drinking water, along with and focusing on probiotics in your diet can be some of the interventions that can be done to improve the gut health. So there are a lot of studies that have shown that probiotics shorten the duration of diarrhea and prevent recurrence of the episodes. Furthermore, probiotics can prevent diarrhea from infection in infants and malnutrition. And also, like educating mothers regarding not to hold off, like we have bathroom visits for the children and the mother is very important, because gut health also impacts your immune system and brain health. So a combination of approach has to be taken when we are looking at the gut health, like like eating a high fiber rich diet, eating like fermented foods, along with the use of pre and probiotic combination can be of great help in reducing infections, in reducing the disease rate, and also which directly affect the malnutrition rate in children. So if the gut health is good, it also impacts your immune system and brain health, which we call it as the gut brain and immune axis. Also, if we can have along with this also, at a supplementation level, I have a very small suggestion that if we can have a single tablet for all the vitamins and minerals for the pregnant women, that can reduce pill burden for the pregnant women. So there are tablets available in which the disintegration time is less than 30 minutes for a single tablet, in which we can have like 14 vitamins and 14 minerals in a one pack solution, and there is sustained release of dosages in this. So we can there should be a creation of products like that, in which we have good amount of major micronutrients that we need to give to the pregnant lady, and also bridging the gap of other vitamins and minerals that need to be incorporated with diet or with supplements. So it is kind of and also when you have a single tablet, it is like kind of easy to remember, which creates less burden for the busy women who has a lot of tasks to undergo in a day. So these were the like few highlights from my side, that adolescents should be educated more and more, so that we have because they are the future mothers. And the second thing is use of probiotics, prebiotics, along with eating a healthy balanced diet should be advocated. And the third thing is like to have something which can reduce the pill burden for the pregnant females. So that is all from my side. Thank you very much.
Thank you so much, Shweta. I mean, very well taken your point on entire approach towards prevention and how we target adolescent girls, child marriage, dropouts, being out of school. All of these aspects really impact ultimately a child malnutrition, which people may not be able to see it, but then bringing this perspective is so important. Working on these aspects is so important. And of course, on the entire idea of the hidden hunger and how a balanced nutrients, balanced nutrition, balanced food in various ways. You've suggested a few ways of one tablet approach and gut health. So a lot of probiotics in the food. So all of these plus a holistic food. How a meal should look like. Initially, what Runa said about 3 colors and on the plate. So all of these does help reduce malnutrition. So I quickly move without wasting time to our next speaker. We have Shiparna Ghoshi, Senior Manager, Sini. You're here. Thank you. Please share your thoughts.
Thank you. Thanks a lot to the Grameen Foundation team for giving me this opportunity. And in this context of child malnutrition, I like to link my presentation with the last 2 speakers, where there has been a lot of discussion, where both the speakers have touched upon the requirement of nutrition during pregnancy. So in CINI, while we have worked on child malnutrition for last 49 years. There has been equal focus on maternal malnutrition also, and I'll be speaking about that experience in this discussion today. So just allow me a minute to share my presentation.
Okay.
Yeah, is it visible?
Yes, yes.
Yeah. So I'd like to focus upon the importance of maternal nutrition, specifically during the pregnancy period. So just a second. Yeah, so when we currently look at the NFHS 5 several malnutrition related data, we find that stunting among children has increased more than underweight, which is 32%, whereas stunting among children below 5 is 35.5%. And we all know that this stunting is primarily a result of intergenerational cycle of malnutrition. So in order to address this issue of stunting, low birth weight, there becomes a big necessity to focus on adolescent nutrition as well as maternal nutrition, that is nutrition during pregnancy. So we all know that if that the improper nutrition during the pregnancy period has quite a few implications. One of the major implications is fetal stunting, which means that the fetus in the womb will not be of the adequate length. So that happens to be one of the major impacts of poor maternal nutrition. And along with that, preterm birth, low birth weight babies, morbidity among women of reproductive age group are some of the major implications of maternal nutrition. So in doing that, what I would like to share today is one of our experiences in implementing the national guidelines on promoting maternal nutrition during pregnancy. So while we look at it, there has been this national algorithm promoted by UNICEF as well as Ministry of Health and Family Welfare, where pregnant women are divided into 5 nutrition risk conditions. The first condition, that is a normal woman during pregnancy, who is called a woman not at nutritional risk, where there are specific cutoffs of her BMI, MUAC, anemia, and gestational weight gain. I'm not going into the details of the indicators. We can share at any point of time. So any particular pregnant women falling within this category is categorized as not at nutritional risk. Now coming to this, what is then at nutritional risk? Now there are 2 categories at nutrition risk pregnant women. The first category is thin and severe, thin and overweight, where there is a little below the normal cutoffs and a little above the normal cutoffs, where the algorithm is classifying the pregnant women as thin and overweight. And a BMI less than 16 or more than 25 is categorized as severe thin or at severe nutrition risk and or medical risk. Like a woman having a very low BMI or a very high BMI may be having some other medical complications also. So given this algorithm, we have a pregnant women falling into different BMI categories: severe thin, thin, normal, overweight, and obese. And we at CINI has been addressing this particular algorithm in the district, in the state of West Bengal, through the specific public health program, the ANC service package. So the package of interventions that we will like to promote for improving nutrition during pregnancy. First, we would like to say that currently our policy guidelines doesn't support screening pregnant women for BMI. So what we did in West Bengal, we partnered with government of West Bengal and used BMI field tables to calculate the BMI status of the pregnant women at the onset of pregnancy. Now, this became extremely important because as long as you can understand that what the nutritional status of a pregnant woman is, it becomes very important that in the entire 9-month period, you can follow up on the different aspect of her pregnancy as per her BMI. So we did this for all pregnant women from 3 districts of West Bengal, that whenever the woman was coming for her registration, the ANMs were trained on how to do this BMI. Just to mention, the normal online BMI calculator cannot be used for this because the cutoffs are a little bit different for pregnant women. So the field calculators you can see in the picture was being used by the ANMs and the BMI was done. Our second set of recommendation includes tracking of monthly body weight. Currently, we all know that as per the WHO guidelines, countrywide 4 ANC contacts are being ensured where the pregnant woman is being weighed. But this happens to be one of the most weakest links, because even if at places this weighment is done on a regular basis, the tracking of the weight is very seldom done. So if a woman is coming between 2 ANC periods at a gap of 2 months, whatever the weight gain has been in that 2 months is hardly being monitored by the ANMs. And even if the weight gain is not adequate by the 8th or 9th month, you have lost the time. You cannot do anything about that. So what we endorse that the pregnant woman is weighed monthly and at the Anganwadi center, because that is the place where the woman is coming on a regular basis to take her supplementary nutrition. That point of contact is already available with the system, and so we use that system, we use the platform to monthly weigh the pregnant women at the ICDS center and track their weight gain. The third thing that we did was introduction of spot feeding. We in West Bengal, ICDS do not provide a THR. It's a hot cooked meal that is being provided. But the general practice that prevails is that the meal is being taken by the women at their home, and in many cases we have found that the meal is being distributed between the younger children in the family, and especially the egg that is being given away to the other younger children, or sometimes even other members of the family. So the basic requirement of the woman in terms of her nutrition, which is being provided by the ICDS, was not met. So what we piloted is that we work with the ICDS department, the ICDS centers, and ensure that whatever nutrition the pregnant women were getting, they are allowed to sit at the ICDS center, sit together, have that social contact within themselves, and have the meal at the ICDS center itself. And along with that, we all know that anemia happens to be one of the major challenge areas in malnutrition among women. And after having the meal at the ICDS center, a supervised feeding of the IFA was also done at the ICDS center. IFA consumption still happens to be a major challenge, and women, due to superstitions, due to some physical complaints, still have that tendency to throw away the IFA tablet and not consume it. So supervised feeding of the IFA as well as the supplementary nutrition at the ICDS center by the women was the third approach that we piloted in West Bengal. Fourth was that we had an additional home contact for a joint home contact by the ASHA and the Anganwadi to the identified nutrition risk pregnancies. As per BMI, whenever there was a pregnant woman who was identified as severe nutrition risk, or at some cases may not be severe but moderate, but with other nutritional complications, maybe anemia, severe anemia or moderate anemia, or other type of pregnancy histories that are complicated, additional home visits were made jointly to these houses, to these families, by the ASHA and the Anganwadi, in order to ensure the family support that this pregnant woman or the nutrition risk woman is supposed to get. And all the issues of family support, rest, dietary diversity, family conflict, abuse, addiction, all these issues were dealt during these home visits by these ASHAs and Anganwadis. And the fifth approach that we had taken was differential nutrition counseling for different BMI categories of pregnant women. You can see in the photograph, we use a nutrition flag where the tricolored food is being mentioned. And in West Bengal, we have found that there were quite a number of pregnant women who were on the higher side of the BMI, overweight, obese. So we developed different counseling messages for underweight and overweight pregnancies, and did the counseling accordingly for the different categories of pregnant women. And this was a very important finding that I would like to share with the panel and the participants, that we were very much under the impression that obesity is an urban problem. But with this, we had implemented this pilot in very remote rural areas of West Bengal, and there has been quite a high prevalence of obesity among pregnant women that is emerging from the rural areas. So we really cannot say that obesity is an urban problem. Maybe percentage of prevalence may be higher, but with our experience, we find that obesity has already penetrated into the rural areas as well.
Shriparna,
So
I
these
think
were the 5 approaches, and we used also quite a few series of simulation games in order to increase the communication coordination among the teams in order to ensure a healthy pregnancy and address the nutrition risk conditions. We have piloted this program from 2018 to 2022. We have trained around 2,800 plus ANMs on BMI and other nutrition risk conditions. The 9,000 plus, in fact, it has reached around 12,000 ASHAs has been trained on nutrition counseling, the different BMI, differential nutrition counseling that I was mentioning about. The program has been rolled out in around 1,600 sub-health centers and 4,500 BHNDs. And on being trained, the ANMs have till date assessed around 1.5 lakh pregnancies, and we find that around 41% pregnancies are either in the low or in a high BMI category. This is for the first time for the state of West Bengal, at least, or maybe for the state of India, maybe, that the malnutrition at the onset of pregnancy has been measured by the system itself, and we are trying to take it to the government for more policy level action and take necessary actions to address malnutrition during the pregnancy level also. We have used this maternal nutrition program kit for training the ANMs and ASHAs. They contain the BMI calculators, short films, training manuals, handouts, scales, posters, which has been used by the job aids, by the ANMs and ASHAs to assess nutrition risk conditions. We have partnered with the Johns Hopkins University to see the impact of this maternal nutrition on childhood stunting. Because as I was saying, that this entire intervention started in order to address stunting among children with the growing concern of stunting in India. And we can clearly see that in the intervention group, which is the yellow bar, and in the control group, which is the red bar, the prevalence of stunting, underweight, has always been low in the intervention group than the control group, and the low birth weight has also been addressed to some extent in the intervention group.
Shriparna, I think we should come to We've exceeded your time slightly.
Yes, this is my last slide. Sorry.
Yes. I mean, we've exceeded your time, so if you could just kind of quickly.
Okay. Yes, this is my last slide. So from the findings, I think we have quite a few policy recommendations. We are working with the government to incorporate BMI as part of pregnancy registration and include the same in ANM curriculums, mainstreaming of monthly weight monitoring, needing for Asia-specific guidelines in pregnancy weight gain, management guidelines for overweight and obese pregnancies, and finally, a multi-stakeholder approach in addressing severe malnourished pregnancies is something that is required in order to address this. So that's it from my side.
Thank you, Shriparna. It was very fast. You touched upon every aspect of how to tackle malnutrition from the start of pregnancies. I think the key takeaway from what you just said is that how important it is to address malnutrition from the onset of pregnancy. I mean, from the beginning itself, and how do we take it through the stages in such a technical manner to see that the child is not born undernourished and does not face this. So thank you so much. And so much of advocacy and reaching out 1.5 lakh pregnant women is a huge thing, and a lot of learning, I'm sure, from your interventions you must be having. And thank you for sharing in detail, and every aspect of it was so important. So as we move on, and we are almost close, slightly delayed, but I think we'll finish quite on time. I welcome Nilima Dhingraji, Director, the Magi. Ma'am, please share your thoughts. You have been waiting for long, so we would like to hear from you.
How much time we have?
No, I think since we started a few minutes late, we are perfectly on time. It's 5:29, so we can take 10 more minutes, 15 more minutes.
Sure.
For you, it's 7 to 8 minutes.
Great, thanks. Thank you, Dr. Krishna, Sudhata ji, and greetings, everyone. It's an honor to be here. I'll just take a couple of slides since we do not have that much time. My fellow colleagues from industry have shared great insights on the best practices using which together we can aim to catch the big ball called malnutrition. To add to these practices, I would like to talk about how at Dimagi, we use digital tools to strengthen the existing ecosystem to tackle social issues at scale. Talking particularly about malnutrition and how digital intervention can help, it's important to consider and design for three key stakeholders. I'll just share my screen. I'll just take a couple of slides so that, just a second. Yeah. Hope it's visible. So is the slide visible?
Yet.
Okay, I'll just go. We don't have that much time as well.
You try again.
No worries. Okay, so I was saying it's important to consider and design for three key stakeholders who play a pivotal role in tackling malnutrition. First being the beneficiary themselves, second one being the government and the health administrators, and the last one being the community health workers. So I'll share examples of how digital can help support each. So starting with the beneficiaries, as many of our panelists already mentioned, that beneficiary doesn't only limit to the children, but also includes pregnant women and even lactating women. We cannot improve nutrition unless we focus on all the critical stages of the child growth, starting from the pregnancy stage when the mother is carrying the child. While it is important to counsel the mothers to bring awareness for the importance of nutrition of their child, at the same time, it's equally important to counsel the pregnant women and lactating women to take care of their own nutrition. And our powering approach, or what we fondly call as ABC model, plays a very significant role here, where A stands for awareness, that is making the mothers, the pregnant women, and the lactating women aware of the importance of nutrition. B stands for bringing behavior change, that is counseling them to seek health services on time. And C stands for caregiving, which will translate into timeliness and quality of service delivery. Now, digital tools can implement this ABC model really well. Almost all the solutions that we build in Dimagi invariably has the counseling modules to bring that awareness among beneficiaries and improve the health-seeking behavior. When I say counseling modules, we incorporate the videos, the audios, and the images, showing those multimedia components as a counseling messages to the beneficiaries really has a long-lasting impact, and the messages get into their brain. Cite an example, Lata Medical Research Foundation partnered with us with Dimagi and adopted a digital tool for monitoring antenatal, natal, postnatal, and infant nutrition in rural India. The core objective of the program was to improve health-seeking behavior in the expecting mothers. And during just a few months of the program, a significantly higher proportion of the women visited the hospitals when they got their advice from the community health workers. So earlier they were hesitating to visit to the hospitals. Earlier they were not able to spot the danger signs in the pregnancies. But with those counseling messages, the health-seeking behavior improved, and they started visiting to the hospitals when they got advice from the community health worker, which indirectly will help the health of the child and then the malnutrition. So to summarize, it is simpler to eradicate the malnutrition problem when beneficiaries themselves realize the importance of nutrition and seek timely intervention. A digital tool can help implement this ABC model and bring in that behavior change among the beneficiaries. Now, moving to the second stakeholder, the government and the health administrators. Now, these health administrators, they need to plan the programs, define the policies, budgets, intervene at the right time, and all they need is a data for this. So data may sometimes feel like a buzzword, but any decision made at the highest level of government is only as good as official understanding the situations. Unless the right data is given to them at the right time, they will not understand the situation. So for example, like if the health administrators are able to get near to real-time data on their desktop related to number of underweight children under 5 increasing in a particular region, they will intervene at the right time and provide supportive solution. So it's very important to provide the right data to the health administrators in real time so that they can provide that supportive supervision at the right time. When it comes to data, another big challenge that we face is interoperability. it's a unified view of an individual from all touch points of the health and nutrition is very powerful way of using data and decision making. For this, we need to ensure that islands of data are well integrated. So for data to be made readily available, it requires robust frontline worker digital applications which can collect the data, analyze it efficiently, and then the data can be made available to the frontline workers, health staff in facilities, and various level of administration for quicker decision and analysis. So it's moving to our last stakeholder, which is community health workers. So a major burden of improving the overall nutrition status of the country is on the community health workers, who are dedicated to provide services to beneficiary, but at times they themselves are overburdened with the record keeping work and creating reports that needs to be submitted to like a number of levels. What if the digital tools can help to reduce their work? They can focus on improving the quality of their service delivery. What if the tool can tell them what to do today? What if tool can give them all the guidance and questions, pulling it from the global protocols and the latest standard? So in short, if the digital tools are able to reduce the work for the community health workers, they can improve the service delivery at their end, and indirectly they can help tackle the malnutrition problem. Citing an example from Nepal, where we use digital tool for maternal and child nutrition, the tool helps the community health worker counsel the mothers at the household level. The application actually told the community health worker that which mother is at which level, what content is to be used to counsel the mother. So the application also prompted the community health worker for a special case visits. For example, if there are any increased health concerns, then the application prompted the user to visit that beneficiary today. That's like a special case visit or an urgent visit to be done. So all this improved the quality of the service delivery out there, and digital tool can definitely help do that. So just to summarize, since we don't have time, we at Magi have realized the importance of digital intervention to strengthen the ecosystem to tackle the malnutrition. And we developed a solution called the Magi Nutrition Solution. So the Magi Nutrition Solution is a holistic nutrition solution which is built on ComCare that is designed to empower the community health workers for enhanced service delivery. And at the same time, it enables the administrators to monitor the program outcomes. So I'll try to share my screen again because I think it will be difficult to explain this unless I have.
Yeah, I think this. Is showing us something, Nilima?
Yeah, I'm just trying to share screen once more because it's difficult to share about these solutions. Is it visible now?
Oh, yes.
Is it visible?
Yes, yes.
Okay,
It's
great.
visible. It was, the slide was visible. Now we can see a document.
Sorry, is it visible?
It was, not anymore.
I think you have to open the way I did it. It was tricking me as well, Sriti this side. So you open the presentation that you want, then you go to screen share, and then it will let you select that. So whatever you want to present that one slide now, first open it in slide share, in presentation mode, and then go to the Zoom share screen.
Okay. Yeah.
Try that. Because we could see it, and I think when you went to the Word document, then we could see the Word document. Perfect. Can see it now.
Okay. Sorry for the issues. So talking about the Magi nutrition solution, we at Magi understood that it is very important to create a holistic solution which will tackle the needs of the beneficiaries, the government, and also the community health workers. So it's a holistic system which caters to all the critical life stages, as you can see at the bottom, starting from the adolescent stage to pregnancy, to lactating, to newborn, to 0 to 3 years and 3 to 6 years of age. And it covers all the major on-the-ground workflows that exist, starting from growth and development, nutrition, counseling, supportive supervision, pregnancy, health checkups, immunization. So basically, it's a holistic system that we have created at Magi, and it would provide near to real-time data to the government and health administrators so that they can do the data-driven decision-making, they can do SAM-MAM tracking, and also share the system with the other systems if it exists. And also another thing which I would want to mention about the Magi nutrition solution is that it's multilingual. It can be available in the local languages. It is it works in an offline mode. That is, even if there is no network connectivity on the ground, the system would work. We know that in villages, like, there are network issues. So the system, the community health workers would be able to use a system even if the network is not there, and they can submit the data at the later stage. So this is something which we thought would meet the needs of all the key stakeholders that I just mentioned. If you want to know more about the Magi nutrition solution, I'll just paste the link on the chat box and just reach out to know more about it. Thank you.
Thank you. Thank you, Nilimaji. It was such a nice and a kind of presentation by you in very short about the importance of digital tools, how to digitize information, how information being digitized really helps us to take decisions appropriately, quickly, and it can impact malnutrition. So all this information that we have, because we all know how the Anganwadi worker has a vast load of noting down every aspect of the entire work that she does. But once the information gets digitized, can actually be seen at one point, can move faster, and really it can be very impactful in terms of giving the service delivery. I mean, improving the service delivery of all the services that we provide. So thank you for sharing your product also. It was very good. I think just ask Krishnaji.
Yeah, so we are really going positive time. So I think we will quickly take 2 questions from the chat, and rest of the things will email those who have quoted the question over chat. Yeah, any panel can answer the question. Yeah. So Sudattaji, any 2 questions if we can quickly take up.
Yes, I think participants, is it open for participant to unmute and speak?
Yeah,
I
think few questions on chat also, if you can see.
No, I don't see any question on the chat.
Yeah, so one question is, what are the opportunities and challenges for reducing malnutrition among Indian children under 5 years of age? How do we scale up projects running across the country?
That's a very vast question.
Yeah, so the second question is, how do we use school MDM or meals throughout the day for programs that provide better nutrition for young children? If any panel can answer this question, how do we use school MDM or meals throughout the day? Is that possible? Government is looking into this or what? Or we can biofortified or fortified meals can be delivered.
Can I add something here to the question? Am I?
Yes, Smriti, please.
Yeah, Hanji. So I'm not sure if I understand your question completely, but in any case, I just wanted to add one dimension to it. Utilizing MDM meals throughout the day. Obviously, you got. there would be budgetary implications to kind of provide the meals entire day. There is a budgetary implication for one. But one of the things that I would like to kind of add here is, in one of the projects, what we had done was, and this was called Fulbari, and this was JSS in Chhattisgarh, and it was a creche program. It was, we can extrapolate the experience there, but the problem there was that children were coming to the creche, and for those 3-4 hours that they were in the creche, and this is a largely tribal population, in the creche they were taken care of. But when they went home, so the majority part, they were in the home environment. So the point I'm trying to make is the intervention that we brought in there was to how to extrapolate the nutrition beyond the Pulvari, and it was by involving mothers, by educating them, by involving family members, so that whatever is being fed is fine, but how that can be done at home when the child spends majority of the time. So there were like kitchen gardens, community gardens, and the know-how. So nutrition is just not giving food. So I think the essence is that basically the interpretation of that, like the Tiranga Khana. So how can the Khana be made Tiranga wherever possible? How can kitchen garden, community garden innovations can be brought together? And whenever I say community gardens and kitchen gardens, there is a pushback saying, oh, itna poverty hai, there is no this thing. Believe you me, I was talking to this, and I have partnered with this gentleman in Haiti who has managed to bring kitchen gardens in urban communities, So where there is a will, there is a way. I think Poshan Abhiyan is creating a lot of innovations. So to answer your question, if I may attempt, the know-how and what that nutrition is in the midday meal, if that can be, and the pathways of doing that thing same at home, and for midday meals especially, it's just not the good nutrition, it's avoiding the bad nutrition as well. Like Ms. Ghosh was saying, it's obesity and NCTs, these are just not in affluent sections. The rural population is equally, if not more, getting affected. So I think the knowledge can transfer. So if that helps in kind of addressing what you were.
I think it does. Thank you, Smriti. Smriti, since you're here and you're responding to the questions, there's one more question also that came up, but I think you almost answer both of them together. But still, let me look at the chat box. If we have something more, I would.
So, Data, I think Manosmita has a question. Manosmita,
Yes.
would you like to unmute yourself and ask your question?
Yes, hi everyone, good evening, and I'm Manosmita, currently pursuing Master in Public Health at Ravensa University, Odisha. And basically, for my knowledge, that I want to ask that as we know that any malnutritional project is going to end after 2 or 3 or 4, 5 years. So how do we continue that, sustain this programs in the community, and second one is that how do we persuade the community health workers that they should know that the importance of nutritional issues, that most of them are there just maintaining registers and like that, but they are not working in an effective way so that they can educate the mother. Yes, thank you.
Yeah.
If I can take that question, especially the first part, where you mentioned that how can the programs run for more than 1 or 2 years. Basically, the program starts with a pilot, it runs for a few years, but then it ends. I think a very important aspect there is that the program to be owned by the government. It would be really important if from the beginning of the project only, the higher officials in the government are involved in the project. That way, they'll own the data and you'll be able to have that long-term sustainability of the program. Like there should be the plan of long-term sustainability from the beginning only, and the plan should be owned by the government. So, ownership from the government is a key to sustain the program for long, I believe. And to your second question, you're right. In many areas, in many countries, the community health workers are still maintaining the paper registers, and most of their time actually goes into maintaining that registers, all that record keeping work and all that manual work. In fact, that affects the quality of the service delivery. So as I mentioned about the digital tools can help them reduce this manual work. They can get away with this paper registers. Most of the work can be done by the digital tool. In fact, the WHO graphs that are created in the registers, they can also be created in the digital tool. So if the digital tools are able to reduce their work, they can improve on the service delivery. And to your question on how can they understand that how to counsel the beneficiaries in a better way. So digital tools can also play a great role in giving them the material, the videos, the images, which they can use to counsel the beneficiaries. For example, in one of the programs, we had to counsel the beneficiaries, the pregnant women, to give the breast milk during the first hour during the first hour of the birth. Once the videos were used to pass on this message, they remember it. And it was also easy for the community health workers to pass on the messages. Otherwise, they'll just pass on the messages. We don't know whether the beneficiaries have understood also or not. So multimedia can play, and digital tool can play a very, very important role in passing on this counseling messages in a better way to the beneficiaries. Hope that helps. Yeah.
Thank you, Nilima ji. Thank you, very well said. I think I just want to ask a small question myself to the panel members. See, from all of this and every aspect of all that you have shared, requires so much of work extensively in each pocket of work. As I would again repeat what Sriti ji said, the larger puzzle and how important work on everything, digitization of records to bring awareness at the adolescence level, and also working on dropouts, for instance. So there is a need for political commitment to tackle hunger and malnutrition. Just what would be the key urgent policy asks from the panel members, you feel?
Okay.
I think a lot, yes, please.
Yeah, thanks. No, I think see, there is political commitment. So there is things are happening with the Poshan Abhiyan and with the district level action that is happening with the all the. I mean, we know the atlas that is being developed and everything, but I think in addition to that, it is very important to see where are the gaps. Now, many of you mentioned, I think one of the panelists mentioned the NFHS 5 data and she mentioned stunting has come down a little, underweight has come down a little, and many of you mentioned about SAM, the severe acute malnutrition. That has actually, there is a 0.1, I think, percentage increase. And I was shocked. I was attending this IFPRI portion, the report cards analysis that was, it's beautiful and huge resource that is there. And it shows that SAM is a public health scale problem in almost like all the districts, right? And somebody mentioned, I think many of you, the community-based management of acute malnutrition. So there are these policy gaps. Do we have still for severe acute malnutrition, are at policy level, our treatment, it is treatment based and it is facility based. So basically things like, yes, community management we all know is required, but if there is a direction that is given, I think that would also kind of go a long way in kind of uniforming the solution, especially for SAM and MAM kids, because they are really vulnerable. So I would, in my dream, this thing, if somebody was looking at this webinar, if some tool that, like Nilima said, in her slide, there was this tracking of SAM and MAM and tracking of so many things. If that evidence can be brought together, can be understood by the community worker, energy can be spent in understanding the evidence and not just filling the records, and then we do the treatment, but the most effective one, right? If your project is going to end in 2-3 years or whatever, even these severe children can't wait, they are more susceptible to infections and they will get, the mortality rate is definitely higher, right? So it is important to understand what treatment or what measures and what works best. And we put our best foot forward. And all this can come from policy directions, from guidelines that can be contextualized at level. So I think I'm thinking in that direction basis what all you said.
Thank you.
Can I add one thing in this? Yeah. So, I mean, one of the policy which I also witnessed in the Odisha recently, that they have integrated millets in the diet of the mother during the pregnancy, eggs, and I think their Odisha government is more focusing on the maternal nutrition, also on the child nutrition. So basically, and which I have not seen in other states also. So I think if there is a political will to improve the nutrition, I think there is a possibility, and which is why like things are really working there. Yeah, thank you.
Any more from the chat? Because my things a chat which I've missed initially.
There's just one more question. I believe it can just.
That's going to be the last question. Yes.
Yes. What do you suggest as a civilian? How can we contribute to addressing these issues?
I'll jump in. I think as a civilian, you're in the best possible place, right? You're not attached to any organization. You are not promoting any, because you have to work around the mission and vision. You have to be guided by that. But I think there are a lot of participatory initiatives that are on. I was associated, like I said, with Pratham's Asar Center. And there is, if you go to the website there are a huge repository of these assessment tools, these rapid assessment tools that have been used to create district level report cards, the Paheli surveys that I was talking about. The H in Paheli stands for health. So if you feel for a cause, I would say one thing, I don't know the name of the person who asked this question, but the one thing that you should do after this webinar is go to the website and look for Paheli toolkits. If you education moves you, if health moves you, if livelihood moves you, whatever moves you, there is a tool, pick it up. Go to the 5, whatever your community, members or domestic help that come to you, or there is a way to reach it, right? Even at Arogya World, the NGO that I mentioned, the adolescent healthy lifestyle program has been digitized, and we are encouraging change makers to come and identify 10 kids in their community to whom, because they don't have digital access, right? There is this digital divide that is there. So we're saying, fine, you be the change maker, you have your laptop or phone, and make sure that these 10 kids, at least they they look at these modules, and the digital ones that are there for addressing healthy lifestyle, and the messages are aligned with Ayushman Bharat's Healthy Schools program. So I think now, especially with the digitization and especially after the pandemic, technology has taken precedence now. There are a lot of ways in which you can contribute. I am associated, just one last thing, with another initiative called SHIP, which is Sustainability Higher Education Internship Program, wherein, so please look at its social media website, social media. There are a lot of initiatives that keep coming up that give that there are call out for civilians to come and contribute. So irrespective of what your cause is, nutrition or other domains, there are a lot of ways in which you can contribute. So
thank you, Smriti ji. Smriti ji, we are delayed, but we are excited with the discussion that's happening. Yeah. And we would still request you to put in the 2-minute video if it's a 2-minute video.
Oh, okay. So that was not. I can. In fact, I shut it down, but I can. But it was not okay. It's an energizer. So those who want to stay. It'll be a good thing. So let me play it. If you allow me 30 seconds.
Is it more than 2 minutes or it's 2 minutes?
It's 1 minute, 10 seconds. But then we have to think about it, and you have to answer some questions on chat. One question only on chat. Okay?
What do you say, Krishna? बोलिए.
जब तक आप से पोल कर रहे हो, मैं फटाफट वीडियो सेटअप कर लेती हूँ.
I don't know how much time.
No, just one question. You have to put on the chat. Just one question. Correct. It'll be a good energizer. Okay. I kind of gave up on it and I said, "Abhi to बहुत देर हो गया है." In fact, I had to move away, so I No, I can't find it now. That's fine. I think let's.
Okay. Okay. Interesting. I think okay. So actually thank you so much. Thank you so much, everyone, all the panel members. I think Runa ji just mentioned that she had to leave. Dr. Sriti Pavaji, Harish Chandji, Shripanna Ghoji, Nilima Dhingraji, Shweta Chandani. All of you have been fantastic, and thank you Grameen Services for bringing so many people together. I initially felt that so many people, maybe it will be very long and sometimes a little boring, but then everybody was so good in terms of clipping their what they had to say in such few minutes, and such rich work across India it's happening. So thank you for bringing such knowledgeable people to the panel, Grameen Services, and how important it is to kind of have these dialogues regularly. So my request to Grameen Services and all the panel members here, that we should be able to continue with these dialogues, bring in various people, CSOs, individuals, like what someone just said, civilians, how they are working, how they can contribute to challenge malnutrition and fight malnutrition. So we should continue with this dialogue every 6 months or on a quarterly basis, bringing in learnings, because we have to stay together to fight this issue. It's been very long, and yet the fight seems to kind of take some more time to kind of even out. So thank you so much, everyone. It was a very good discussion, and move to you, Krishna ji.
But we can't close, Sudata, or without saying that time management, the credit also goes to the moderator, which is you, who was polite but firm. So yeah, Krishna, please.
Thank you.
Yeah, so thank you so much to all the panelists. It was actually really very good and interactive and informative session. Though initially we thought of be in time and cut short the information that panelists are providing, but I think as Dattaji said, that yes, all the sessions and all the speakers, whatever they informed us, is really, really very effective. And we, as suggested by our moderator, that yes, definitely we are also looking into establishing a group where I'm planning to have share our experiences over that group. But it's still in the very initial phase. But definitely I'm going to come up with that with all of you, and maybe a few more organizations I'm going to involve in that group. And we are also planning to have a series of webinars in this health and nutrition thing. We will capture where children malnutrition, as well as the pregnant ladies malnutrition. Even the lactating women's malnutrition is also important when we are talking about children. Yeah, so thank you so much on behalf of Grameen Foundation India and its entire fraternity and the organizing committee. I took immense pleasure to propose a vote of thanks. First of all, my very, very big thanks to the panelists, our moderator, who runs this session so smoothly, and our speaker who take out time from their busy schedules to attend the webinar. Thank you. Thank you very much for your contributions, patience, your time, and for putting up with my constant email and WhatsApp to ensure that you will be here. Thank you for attending to me, panelists. My heartfelt thanks to you all for all coming together as a collective approach and trying to create an enabling environment. I would like to extend my thanks to everyone who helped me in pulling this webinar together, especially Grameen CEO, Mr. Prabhat Lab, for supporting me to organize the webinar. Thanks to all my colleagues who came to rescue me on the various paths while organizing this webinar. My special thanks and acknowledgement to Grameen's communication team for all technology support at any moment's time and for handling the webinar. I could not hold any of this without your support, really. I am really, really grateful. Last but not the least, a big thanks to all my audience participants who participate so enthusiastically for the entire webinar with constant encouragement, and will take this dialogue forward for such productive discussions. Thank you very much. Thanks to all for being with us this evening. Have a wonderful evening ahead. Yeah, thank you.
Thank you.
Yeah.
Thank you, everyone.